Hello and welcome from beautiful Vienna. My name is Aletaha. I'm a rheumatologist working here in Vienna and I'm president-elect of EULAR. With that, I have the privilege of speaking about the future of EULAR. And whenever someone needs to speak about the future of something, they have to be careful not to be too revolutionary, but also not to be too pathetic. I will try to do that today. But talking about the future of EULAR may not even be as difficult, because we are all here as a community to shape the future. And with that, we can look at what EULAR has done and is doing in his 5 major areas, which is advocacy, education, the Congress, quality of care, and research. And today I will reflect a little bit on how these areas may develop in the future. And at the end of the day, all we are doing, all these activities, ultimately have one goal and are targeted towards the good of people with rheumatic and musculoskeletal disease and the good for society as such. Rheumatic and musculoskeletal disease, it's over 200 entities affecting about 120 million people in Europe. That's a quarter of the European population. RMDs rank second most as reason for consulting a doctor and are the #1 cause of disability in Europe. They're also the #1 medical cause for long-term sickness. And with that, they are a major contributor not only to individual impact, but also to societal and socio-economic impact. You can see I've presented quite a few numbers here, and numbers are important. These numbers come from RheumaMap, which was an activity started a few years ago to really lay out a research roadmap and to allow to tackle priorities for research funding in Europe. But these numbers are important also for the future to generate, and EULAR is planning to do so by probably going into a complete registry of RMDs and to provide these numbers for future activities and also for future advocacy on the European level. Now we're already at one of the key components of looking into the future, and that's the future of patient care. How do we ensure that rheumatology care reaches everyone we need to reach? How can we bring patients and the provider closer together, regardless of physical distance? And we all know and are aware that the density of rheumatologists is much higher in urban areas than, for example, in rural areas. But when you look across Europe, you find between 10,000 and 200,000 people being served by one rheumatologist. So it is essential to understand how we can really reach everyone. One of the buzzwords here is telemedicine, and we all got acquainted with telemedicine during the COVID pandemic over the last 2 years. And this is also reflected in the number of publications in high cited journals on telemedicine and telemedicine research. Telemedicine is the remote delivery of healthcare services, and that can include exams and consultations over some telecommunication tools. And telemedicine is here to stay, and we as EULAR need to support also telemedicine and telehealth approaches to serve the communities that we are currently not serving as well as rheumatologists. Furthermore, telemedicine consultations of new patients may be facilitated or augmented by artificial intelligence and AI. That's the next buzzword. And what is it? Artificial intelligence is, in principle, the simulation of the human process by machines or computer systems. Not only that, these processes include the learning, reasoning, and even the self-correction that humans are able to do. AI is already part of medicine and different fields of medicine. It is it has shown to be equivalent or even superior to physician-based diagnosis, for example, for diagnosis of pneumonia on X-rays, for diagnosis and understanding skin cancer and skin cancer types, and for diabetic retinopathy. So interestingly, a couple of years ago, there was a paper in JAMA reflecting on clinical decision support through artificial intelligence tools. And the authors there laid out a few rules for that. And I would like to spend a minute on reflecting on these tools, because AI is here to stay and we need to think about how we integrate it into our daily clinical life. The first rule was that black boxes are unacceptable. We need to know what happens behind the scene of artificial intelligence tools. The second one is also very important. Time is a very scarce resource. So it should be time efficient, and therefore it should not be complex, and it should be usable. Another point that is very important is that the delivery of the knowledge and information by these tools should be respectful. And that means it should be respectful to the person, to the physician, the doctor utilizing it. And of course, every information that comes out of these tools or is the basis of these tools needs to be evidence-based. Now, artificial intelligence, it doesn't always need to be artificial intelligence. We can also think about empowering ourselves with natural intelligence. And I'm showing here a world map that is colored. Some countries are colored, some are not. And this is all the countries that have licensed a certain TV show, which we all know, Who Wants to Be a Millionaire. And since everyone knows that, I thought it was a good example, because this show has a few features that I would like to focus on. You know, the lifelines during this contest. There is the phone a friend. And we were just talking about artificial intelligence, and I was making the point that natural intelligence might be helpful. So phone a friend is a classical example of how you can use some minded person to use their intelligence to solve a problem. And EULAR is actually doing this with consultancy services. So in fact, EULAR has implemented this. The community across Europe can consult one expert in the field with their specific research questions, with any type of detailed problems they have during a certain type of research, and EULAR can provide the connection and the hopefully solution of the problem. So this is calling one person that is an expert. Usually that's what happens with phone a friend. However, I would like to make a point and maybe a little prospect for the future about another lifeline, which is Poll the Audience. So Poll the Audience includes more than one mind. It includes 10, hundreds, and it could theoretically include, when you think about a community like EULAR, thousands of people. Maybe an important note, after 15 years of the show, the Poll the Audience success rate was over 90%. And these are not experts, these were just people in the audience. The phone a friend had a success rate of 66%. So how about utilizing the power of this community for the purpose of serving diagnostic processes in rheumatology? Using or utilizing digital tools that engage natural intelligence. And with that, I'm at a key point that I would like to make today, the power of the community. For diagnostic processes in clinical medicine, in clinical rheumatology, it's not about engaging the knowledge of a person so much, or the knowledge of the community. It is going beyond that by adding each individual's experience to the table. And in clinical diagnostic processes, we all know experience is something that we value highly. We all go to an experienced doctor rather than to a non-experienced doctor. And if you think about hundreds and thousands of doctors, the diagnostic process is more and more likely to be right. And EULAR has a great community. It has 45 scientific societies, 24 associations of health professionals, 36 patient organizations, 27 corporate members, and as of this year, individual membership. Individual membership means that the whole European community working in the field of rheumatic and musculoskeletal disease are able to join EULAR in person, increase the community, the individual community. That said, I would like to move to another item in patient care, but also in research, and that's about the big data. You could call it big data problem, you could call it big data challenge, but fact is we generate a lot of data and we have arrived at the era of polyomic patient care, where we do not only collect clinical markers or even electronic medical health records, we have variables that permanently collect information from patients, from the patient's wrist. We have all the social media and internet activities of individuals that contribute to information. And of course we have the biologic platforms, the omics, that allow us to really go into molecular medicine and generate an incredible amount of data. And I would like to start with the omics, the polyomic data. If you look at this chart here, looking back to the Human Genome Project, that when it was finished in June 2000, the sequencing or the draft sequence of the first human genome costed about $300 million. And after that, from 2001 to 2021, over 20 years, the cost of sequencing a human genome dropped by 100,000-fold and is far below $1,000 or euros today. Also, there is chips, array chips, that cover a whole genome-wide SNP, the whole genome by SNPs, and therefore allow to create a library for each patient, the individuality of each patient. And with these SNPs, polygenic risk scores can be developed that can be predictive of certain disease or help to be diagnostic with certain patients presenting. An example I'm showing here is a polygenic risk score for all the SNPs that were associated with hypertension. So you put them all together, each one of them is not very useful, but putting them all together creates a numeric scale. And you can see if you put patients by quintile of this polygenic risk score, and on the left, and you look on the right, what's the rate of individuals in each of these quintile developing hypertension, you can see that it's clearly genetically driven and that it's a marker that can help us as physicians maybe better categorize patients or streamline diagnostic processes. And who knows, these multi-array chips are incredibly inexpensive by now, and maybe at some point we will check in with our doctor with a problem, not only with our insurance card, but also with the SNP array on our smartwatch, and help the diagnostic process in this way in the future. Speaking about polyomic data, we can look at the genome, and considering that the first draft of the human genome sequence that was finished in June 2000, it cost about $300 million to finish this. And if you look at the development of the costs of sequencing one human genome over the past 20 years, you can see that the costs decreased by 100,000-fold and currently are far below 1,000 euros or dollars. Also, you can do this genome-wide SNPs arrays, so single nucleotide polymorphisms that cover the whole genome and create a fingerprint of the genetic variability of an individual. And with this fingerprint, you can create polygenic risk scores that allow diagnosing or facilitating diagnosing and predicting disease in a much more efficient way. And an example here is giving for hypertension. If you take a polygenic risk score for hypertension, so put all the SNPs that have been associated with hypertension together and classify patients by quintiles of these polygenic risk scores, and then look at the actual rate of developing hypertension in these 5 quintiles, you can see it's clearly predictive and associated with the genes. But also gene expression has made dramatic movements forward. And if you look at this paper here, speaking about the revolutionary tool for transcriptomics, RNA-seq, something that was presented in 2009 as a revolutionary tool and was predicted to be revolutionize the manner in which eukaryotic transcriptomes are analyzed. And it, in fact, was a correct prediction. And today we are sequencing the RNA not of bulk of cells, we're sequencing RNA of single cells, and we are continuing to use this in the purpose of diagnostic processes as well as in better understanding of pathophysiology of disease. But data goes far beyond omics. Data is everywhere, and today we generate more data than ever before. If you think about the smartwatches, and that's only one example, health trackers, but also all the activities we do on the internet, every activity on social media creates some sort of information that might be useful or not in the terms of health and diagnostic processes. But with all these data, one has to ask, who can analyze this data? How can we analyze? How can we handle this data? So when George Moore, one of the co-founders of Intel in 1965, posted that roughly every 2 years the number of transistors on microchips would double, his theory became a hallmark theory of the 21st century and is now referred to even as Moore's theorem. He was right, but he was wrong at the same time, because the development was even much faster. And if you look at the number of transistors on microchips, as shown in this graph here over the years, you can see that the axis, the y-axis, is logarithmic. So the evolution of computational power was unpredictably high and continues to be so. At the same time, the average costs of transistors dramatically went down. The average cost of storage went down dramatically, and internet connection became dramatically faster and considerably less expensive too. So all these developments together allow us today to actually handle all the data that we generate today, and it grows somewhat with the amount of data even. So to my final part, and this cannot be left unmentioned, we need to think about age-related disease. We know age-related disease are very common. It's atherosclerosis, cardiovascular disease like hypertension, diabetes, cataract, Alzheimer's disease, but also in our field, most prominently osteoarthritis and osteoporosis. And in rheumatology, and this is from Versus Arthritis, this is a multi-stakeholder charity, I think, in the UK, but they have developed nice data from the UK perspective, where you can see that when you take all the musculoskeletal and health and rheumatic diseases together, and many age groups beyond the 40s and 50s, they make up 2/3 of individuals. So 2 of 3 people, 2 of 3 of us will develop musculoskeletal and rheumatic diseases, and most of us will have some sort of age-related musculoskeletal disease as well. So this is something that we need to tackle in the future. Tackling cellular senescence might be one aspect, and this has been shown to be dramatically effective in animal models, and a potential target also for human age-related disease, a fascinating story, but this is certainly also something that will more and more be important in the future. So coming back to our mission, and to sum up, the future of EULAR shall be based on partnership of all its constituencies, engaging the community, be digital and human, provide resources clinically, scientifically, and for education. And it shall be following the principle of service delivery, community support, prime communication. And all this embedded in a logical and permissive infrastructure that is non-for-profit and viable and accessible for all of us.